as Dr. Sweta has already mentioned, we'll present it in a bit different way. So first we'll go to the questions of the case and okay. So there was this man presented to us with a sudden decrease in social interaction after months of increased psychomotor activity and overfamiliarity. Now the first clinical entity that came to our mind was bipolar affective disorder. When we probed further, we saw that this rapid change in condition was after certain people beat this man due to some brawl, and with that, our clinical entity that came to our mind was post-traumatic apathy due to the head trauma. After that, we found that these previous episodes of such low mood and decreased interaction had been occurring after a probable event of stroke. So then we found, we thought of some secondary mood syndromes due to cerebrovascular disease. Lastly, we also found that this beating of the man was due to him being caught red-handed stealing objects, and multiple such occasions have been there when he was caught like that. So some of the other differentials that came to our mind was impulse control or kleptomania, as we often call it, impulse control disorders, post-stroke syndrome or frontal lobe syndrome, or maybe doing under the influence of a substance. So all these queries need to be answered. So let us go to our case presentation main. So, other than this, there was also, when we probed further, we had found in the sleep quality, the wife reported there was quite snoring in the last 2 to 3 years. And with this, the patient was also found to be obese, and there was daytime sleepiness on most days in the last 2 to 3 years. So Mr. M, a 53-year-old male, Hindu by religion, educated till class 4, is a driver by occupation and is married, lives in a joint family. The informant is self and wife. The information seems reliable and adequate. Chief complaints or the major issues that we found in this case were low mood, decreased interest in work and social interaction for the last 7 years, which was episodic in nature and acute in onset. Snoring developed during sleep for the last 2 to 3 years, which were insidious in onset and continuous in nature. Tall claims, increased energy, overfamiliarity for the last 1.5 years, fluctuating course, and sudden change in behavior resulting in decreased social interaction activities for the last 2 weeks. So, as we can see in the timeline here, at around 2014, the wife reported the patient was actually a driver, and he was when they would talk over phone, the wife reported there was a certain slurring of speech. When she told the patient to get himself checked up, then he went to the doctor and he was given a diagnosis of stroke. He was treated with medications that time. Afterwards, at around 2015, 6 to 7 months after this episode, there was a certain low mood that was developing in the patient, which would remain most of the time in the day. He would interact much less with his friends, colleagues, and also the family members. He would often hold very negative views of the future, telling that his life is of no use anymore. He started gradually absenting from his work, going to his routine trips, and almost stopped his work altogether after 3 to 4 months of such symptoms. This kind of symptoms was actually treated with tablet escitalopram, 10 to 20 milligram per day was given, and it was actually continued till around 2000, mid of 2019, I would say, and the patient was maintaining well with that. Since they stopped it at around 2019, after 9 to 12 months after that, again he had an episode which was similar in similar symptom-wise. Only thing that it now had some self-harm ideations, occasional aggressive outbursts, and almost a very decreased appetite, which was not there in the previous episode. So this time around, again, they went to the doctor and they were treated with certain antidepressants, which I am coming later on. During this time, the wife noticed that beginning from around 2017-18, he was having difficulty in calculating money or in certain transactions of his profession, and he would also avoid doing the transactions in any shopping or any kind of markets. He would tell his wife to do so. So as I was telling, the low mood in the second phase was treated with sertraline 50 milligram per day, and it was being treated for 6 to 7 months when he started having a quite reversal of symptoms that he used to have previously. So there were an acute onset of elevated mood, which would be characterized by him humming songs or singing most of the time in his day. He would also go to nearby shops and start chatting with people who he would not know previously, and he would tell them about certain plans that he is buying such and such things, which is not actually according to his financial status. So he would often have some tall claims. In addition to that, he would be quite authoritative in his behavior. He would often tell his family members that whatever he is thinking, however logicless that might seem, it is true, and they have to abide by it. So additional to these symptoms, there was a certain behavior that he was developing. The wife also noticed that he was in a maybe in 15 days or 10 to 15 days, he was going and stealing things from his colleagues or maybe some unknown persons. So these stealing episodes were mostly done in a planned manner, and they would be he would be stealing automobile parts which would be necessary for his own auto rickshaw, or maybe he would sell them in the black market. So there were some instances that was developing. These symptoms had developed by 2022, and he was being treated at that time by quetiapine 100 to 200 milligram per day, and sodium valproate 250 to 500 milligram in fluctuating doses per day. Now, with this, he was having a partial disappearance of the symptoms, but again, the baseline was never touched. And in the end of around September to October of 2023, these symptoms had reappeared with a greater intensity. And he was also very irregular with his medications. So when these symptoms reappeared with a greater intensity, the wife told that the patient was stealing quite a lot, and one of those instances, the patient was actually caught red-handed, and he was beaten up by the other persons. We'll come to that later. Just a few bits of history regarding his sleep. We had actually inquired about his sleep because of his complaints of dozing off during daytime, and also his general appearance and structure that we found was quite obese. We found that the patient had a gradual onset of snoring, which progressed from a few times a week to every night. The intensity increased over the years to grade 3, which was excessively loud snoring, which could be heard in the other room. It was present throughout the night and was not confined to the supine positions. It was present in all the positions of sleep. It generally occurred during the inspiratory phase, and previously it was continuous throughout the night, but later on it developed a fluctuating intensity, which would suggest that there was a loud intensity followed by a certain pause, and then again there would be loudness. So probably it was interrupted by breath pauses or choking spells, resulting in microarousals. With this, the patient also complained of sleepiness during the daytime. He would doze off often. He would spontaneously wake up a few moments after. The patient would complain of tiredness and lack of energy during the whole day. Only these symptoms of daytime somnolence and fatigue had diminished during the period of overt cheerfulness. Only that time it was diminished, otherwise it was there. So after the patient was picked up, his overt cheerfulness, overt familiarity, increased activity suddenly disappeared. He started remaining indoors mostly, not going to work and talking very less, and he did not voice any depressive cognitions during that time, just that his interaction was decreased. He was brought to AIIMS OPD on February 2023. Coming to the negative history, although there was some self-harm suicidal ideations, but there was no such attempts, no history of harm to others, no history suggestive of any delusions of poverty, ill health, persecution, reference, grandiosity or love, no history suggestive of crying spells, no history suggestive of any prolonged posture maintaining or anything that would be suggestive of catatonia, no history suggestive of any seasonal variation of moods, no history suggestive of hallucinatory behavior was also not present. Nothing suggestive of obsessive nature of any thought or activity was present at that time. In the intervening relative normalcy period, there was no history of any dysinhibited behavior or any emotional lability or aggressive acts during the period of relative normalcy. No history suggestive of any episodic hypersomnolence with hyperphagia or hypersexuality, mainly to rule out the periodic hypersomnolence disorders. No history suggestive of any sleep deprivation followed by compensation in nocturnal sleep. No history suggestive of any kind of circadian shifts in his sleeping routine. No history suggestive of any sudden onset weakness of any limbs or whole body part with laughter, crying, or anger, which would suggest of cataplexy. No history suggestive of any wheezing. No history suggestive of any substances other than alcohol. We have already started the history from 2014, so previous to that there was no significant complaints. History of hypertension was there since 2014. Other than the treatment history mentioned earlier, he was taking off and on these tablets, Icosapent AB, telmisartan, amlodipine, navapril, and mostly these tablets he was taking. He was quite irregular with the medications, but in some periods he was also consistent. In the family history, the main thing from the information that we got, the main thing to note was that his grandfather, two of his paternal aunts, one paternal uncle, had actually probably died of cardiac events, and an elder brother had died of probable leukemia. Other adequate informations are not available. So there were quite a number of cardiac events in the family which led to fatality. Not much of history is available regarding the birth and development or childhood, since no such informant was there. He studied up to class 4, dropped off. In occupational history, as I have mentioned, by 2015 he was absenting from work and actually stopped going altogether. But after 2016-17 he started driving an auto rickshaw, continued till 2020, and then again when the periods of overt cheerfulness started, he started absenting. A bit about the substance use or alcohol use that he was having. He was having an alcohol use for 35 years, mostly twice per week, quarter whenever he was using. Some increase was there during the business months of cover. Otherwise, in the periods of low mood, he was abstinent. And in the period of overt cheerfulness, it had increased to almost daily, 2 to 3 quarters per day. But there was no evidence of salience in that. He was taking, the frequency had only increased. He was married for 36 years, arranged marriage, and most of the responsibility of the household was on the wife because he was staying outside mostly. Only the financial issues were being handled by him. There were frequent interpersonal issues due to his lack of responsibility both before the period of illness and after during the period of illness. In the pre-morbid, whatever information we could get, there was some evidence of self-centeredness, which may suggest some dissocial traits, but again, confirm it is difficult at this point of time. In the physical examination, the notable parts which were there was that his blood pressure was around 140/90. His BMI was around 32 kg per meter square with an increased waist circumference and neck circumference. In the craniofacial examination, we actually got a grade 4 airway, macroglossia, submental fat, high arched palate, which was quite suggestive of him having an obstructive sleep apnea. Significant positive finding we found in our neurological examination was that his deep tendon reflexes in knee, ankle, and biceps were exaggerated. Although his finger nose test and rhombus were negative, his tandem gait was he could not do it properly. He had a wide based gait with short steps. He also had difficulty while doing his alternate hand pattern test. He probably was having dysdiadogynesia at that point. No evidence of nystagmus or titubation could be found. In the mental status examination, when we applied the Hindi mental status examination, there was certainly a deficit in his concentration abilities and his serial subtraction abilities, and his partly deficit in his recall. So he was given a score of 22 by 30, which would suggest a mild impairment in cognitive abilities. When we went to the lobar examination, this is where we found his frontal lobe tests were quite impaired. He could not do most of the digit backwards, weekdays backwards, serial subtraction again, only first step was done. He did nothing of the similarities test. The lexical fluency was also very less. The verbal fluency that we checked was also very less. The Luria's three test, or the motor test of fist, palm and edge was also not completely done by him. Could not complete the test. The go-no-go test again greater than 2 errors, severe one. Luria's test, as you can see, the graphic Luria, he has not conformed to the pattern, and he has drawn actually a continuous pattern of the acute angles. So we can here say that he had quite a few lobe deficits, quite a few deficits in the frontal lobe tests. In the parietal lobe test, however, he was doing mostly his test, no evidence of apraxia or any difficulty in gnosis. His right-left orientation was quite normal. His memory, barring some of the recall, most of his memory were preserved, and he was not having any difficulty in comprehension or reading, writing according to his educational background. No gross deficits in the occipital lobe. Construction ability, however, he was having difficulty, which would, construction ability obviously involves most of the lobes, so maybe because of the deficits in the frontal lobe, he might have deficit in this construction ability. We also did a full mental status examination, but I'll just run through the main parts which were on the day of admission, which were very much important for this. He had decreased psychomotor activity, decreased tempo, decreased speed and volume of speech, quite a restricted range of mood. So he was not showing much. He was not showing much of emotions. The thought flow had also decreased. So it was this thing was suggestive of either an apathy or maybe a depressed mood that we were trying to clarify later on. We went to the investigations part. The main investigation that I thought was important was slightly raised TLC with neutrophilia and a raised HbA1c. His lipid profile and thyroid functions were normal. His non-reactive profile of hepatitis, HIV and HCV. His fasting blood sugar and postprandial blood sugar were actually sent, but due to some technical errors they did not come. We have sent it again. Coming to the neuroimaging part, MRI was done. We could find here that there were certain subdural hemorrhage in the cerebral convexities, the temporal convexities, which were going to some extent with the neurological findings that we are having. In the other sections, we could also find that there were periventricular hyperintensities, and which according to the radiological diagnosis team was significant of probably recurrent CVAs or maybe silent ones even. So there were certain microbleeds in these frames also. An MRI angiogram was also done, which suggested certain atherosclerotic plaques in the arterial system. Yeah. As told earlier, we had suspected him of OSA, so we had done a polysomnography, diagnostic one followed by a titration one. So in the diagnostic one, I can here show you that there was significant desaturations during his sleep, and there was quite a few number of events of hypoapnea occurring here, and even apneas were present during his sleep. So the total apnea-hypopnea index came to be around 37.5 per hour, which was in the severe category. More than 30 we call it a severe. Desaturation index and snoring index are also very high. So we proceeded with a titration PSG, where we can see that we have given CPAP pressures of we have increased the pressures throughout, and seen that around 9 centimeter of H2O there is almost disappearance of snore events and the flow events. There is no apnea or hypopnea here, and even the SpO2 events had also stopped. So he was prescribed a pressure of 9 centimeter H2O, and with this the AHI came to about 6 per hour, which was more or less normal, and both snoring and desaturation decreased completely. Now we come to the first slide that we had put up. So with
which is from the house, if there are any. Ma'am, can you proceed with the slides? Yeah, please proceed.
Okay, ma'am. So with these information, we had narrowed down our diagnosis to that it was a mood syndrome, obviously, but it was a secondary mood syndrome developing at an atypical age of onset, which is around he was developing it around 50 years plus age, and he was developing it which had a temporal relationship with the probable cerebrovascular event. With this also, we had confirmed our diagnosis of obstructive sleep apnea hypopnea syndrome. Also, the deficits that we were finding in his lobar examinations could suggest a vascular cognitive impairment, which was present from around 5 to 6 years previous to this. However, we were not sure about the activities of stealing which were going on. It was still unclear whether it was going on only during the period of his overt cheerfulness and over-familiarity, or it was present in the period of. So that was still unclear, and the patient was not that communicative to come out with his cognitions during that act. So that was the issue which still remains unresolved. So the diagnosis part that we are putting up was between these our most probable diagnosis was secondary mood syndrome with obstructive sleep apnea hypopnea syndrome, hypertension, diabetes mellitus, obesity, subdural hemorrhage, and alcohol hazardous use. Cerebrovascular diseases were present recurrently with vascular cognitive impairment. So this was the whole set of diagnoses that we utilized. The treatment we had after doing a pre-lithium workup, we had they decided for treating him with lithium as a mood stabilizer, and it was actually started at 600 milligram, but after doing lithium levels, we found out that the lithium level was a bit high, around 0.8, so we decreased to 450 milligrams per day. With that, our neurology colleagues had started ecosprin AV and amlodipine. Appropriate referrals, as I told earlier, we had sent the test again, and referrals are being done for diabetes mellitus. Weight reduction was advised, which could help him in all his, in most of his, in his problems related to sleep, related to his metabolic disturbances. So that was advised as a part of his treatment protocol. For treating of obstructive sleep apnea, the best option of CPAP was given as I told earlier, at a pressure of 9 centimeter with a medium-sized nasal mask and a ramp time of 30 minutes. When he came to us for follow-up after 2 weeks of discharge, he was on regular medications. No overt cheerfulness or any depressive cognitions were faced. There was slight betterment, not a great improvement, but a slight betterment in initiative to do work and interaction. He was, however, not using CPAP because of certain reasons of affordability. It is a costly machine. He was having a mask preference which was not still there, and there was certain stigma bound to the machine which in his locality he would be telling that it would seem that he is very sick and because of using the machine. So that those were CPAP at that point of time. So our plan at this point is basically to monitor his lithium levels, also to re-evaluate him for his lobar functions and his neurological examination, as almost 1.5 to 2 months have passed after his head trauma. So those will be the plan in our next follow-up. And to again sensitize him about CPAP would also be our plan, but we are hoping that he will use it.
Thank you, Dr. Kaustav. So this particular case was particularly challenging for us for the multiple comorbidities as already discussed. So this is a man who had presented in his 50s with symptoms of low mood and again episodes of over cheerfulness and increase in level of activity. Along with that, he had stroke, plus he had diabetes, also occasional usage of alcohol. All of these predispose the person to develop metabolic syndrome or derangement of metabolic indices. Also, we saw that the patient had like multiple lacunar infarcts, and this kind of patients, they are much more prone to develop vascular dementia as an ultimate outcome. So the cognitive impairment has already set in, which has been coupled by the subdural hemorrhage due to the beating incident that we saw. And these kind of patients become a challenge for the caretakers as well, because the behaviors may or may not be particularly taken care, by the medications. So
yeah, so we had just to wind up, we had a few literature search. Although it is quite common, we know about this, but then again we can just go to the odds ratio. We are seeing that in patients with OSA, there is a high risk of cardiovascular diseases and stroke. They go hand in hand almost. We also have seen that overall prevalence of sleep apnea is pretty high in the patients with stroke. It is ranging up to 80%. Also, post-stroke depression is a well-known entity. However, bipolar disorder or mania after a cerebrovascular event is still limited to some number of cases, case series and case reports. Even in 2021, we are having a case report of post-stroke bipolar disorder. So these are still not hugely common. Obviously, 1/4 of patients with OSA would likely be having clinical depression. We have seen in our sleep lab also. So these are the things that are quite interrelated. I would like to conclude my presentation with this slide where we are seeing that there is this triad of mood disorders, cerebrovascular diseases, obstructive sleep apnea, complicated with probably a metabolic syndrome. Although this case was not meeting all the characters, but still this metabolic syndrome would play a huge role in this. We know that mood disorders, cerebrovascular diseases and OSA go hand in hand. They can influence each other through various mechanisms, and metabolic syndrome can actually influence all of these. So holistic management in this regard would be required. Just concentrating upon the mood disorders or CVA or any one of the individual disorders would not help us. We have to we have to keep an open eye during our clinical examination about all the things while discovering one. So that would be my presentation. Thanks.